Good morning, everybody, and welcome back to the Pelvic and Acetabular Fracture Management Essentials course. We are in week 7 now of our Pelvic and Acetabular course, and today is a panel discussion, an expert panel discussion on acetabular fracture management. I'm joined by Dave Stephen Toronto and Stephen Sims from Charlotte, North Carolina, in chairing this this 8-week course. This course was, of course, modeled after the first COVID online essentials course, which was the osteotomy course, and has followed on the heels of that course. We continue to learn from what we do each week, and so this continues obviously to evolve over time. The idea is still that this is a hybrid course with a face-to-face component that would ideally take place at the Equendo Center in Las Vegas, pending, of course, the global pandemic. But we still plan, if it is able to be offered, to offer preference to those who are registered for the entire online course session. All the lecture sessions are recorded and CME is offered, and the lectures are all hosted on the AO Trauma North America YouTube channel and are available to be watched individually or as an entire course. We have been very fortunate to have extremely distinguished and experienced educators joining us for the course faculty. You can see them here week to week, joining us and offering their expertise to you all for pelvic and acetabular fracture management. The expert panel discussion, both today and Thursday, we have these 6 faculty members joining Dr. Sims and Dr. Stephen and myself. We have had a couple of changes to today's panel due to some family commitments that have come up, and so Dr. Johnson and Dr. Stover may be able to join us remotely from the car, but will be able to join us in on the for the Thursday session. These are the disclosures of all the faculty members presenting today and Thursday. So again, in terms of Zoom etiquette, all the microphones have been muted, the videos are turned off. Please use the Q&A section for questions that you have regarding to the cases. Do not use the chat function. We're using the chat function to pass information between the faculty members, and so it gets very difficult if the participants use the chat function as well. Please use the Q&A function for questions that you may have. And we will be fielding those questions, collating them, and presenting them to the faculty as we go. The homework assignment, oh, sorry, that is for afterwards. Okay, so I think without any further ado, I'll go ahead and turn this over to Stephen Sims for the first case presentation and discussion. For the rest of the faculty, why don't we keep on mute until until you want to interject with a comment or a discussion point.
Great. Before I get started, Mark, you can see my screen okay?
Yep, looks good, Steve.
All right, great. Okay, good. Well, thank you very much, Mark. It's a real pleasure to be able to show a case at this. This has been really an exciting 7 weeks, and it's been fun to do this. And it's gotten, sadly enough, in my life, it's gotten to where I really look forward to Saturday morning and signing on and learning more about the pelvis and acetabulum. So great fun. So with that, I'll get started. I'm not going to really give you any objectives because we'll have some take-home points at the end, because I just want to let this case kind of evolve, and I'll look forward to some input from my colleagues in crime here. So this is a 51-year-old patient You can see fairly young, but with an extensive list of medical problems, included diabetes, for which he takes pills, PO medication, but is poorly controlled. He is still a smoker, smokes 2 to 3 packs of cigarettes a day, and has significant COPD. Hypertension. He's had a CABG from a coronary artery disease. He has chronic atrial fibrillation and is on Eliquis and has a pacemaker in place. So these are what he brought to the table, and this is what he came with. He actually arrived at an outside hospital. He was hypotensive there. They gave him some crystalloid and 2 units of blood. He was a brief responder, but they packed him up in an ambulance and sent him emergently to our hospital. He arrived at our hospital. He got started a massive transfusion pack. He got about 6 to 8 units of additional blood in the emergency department, and was found to have a hemoperitoneum on his FAST exam. He also had a hemopneumothorax, for which he had bilateral chest tubes. And on his pelvic x-ray, he was noted to have a hip dislocation with an acetabular fracture. He was taken emergently to the operating room. He underwent exploratory laparotomy. He was found to have a liver injury that was controlled the bleeding there. It had a splenectomy for a ruptured spleen. And this was his injury AP pelvis x-ray you can see here. And I think we don't need to belabor the diagnosis here, because this is, I think everybody can recognize this person has an intact iliopectineal and ilioischial line, and has a hip dislocation with appears to be a very large posterior wall. I think the other key points here, at the end of the laparotomy, he was taken straight back to the intensive care unit because they were still resuscitating him. And the residents made several attempts to do closed reductions. If you look, there are probably 4 or 5 x-rays where they look always like this. And I think the key thing that's important here is if you look, his radiologic roof, that's how much he has intact. The rest of it is over here. And if we look at his attempts at his to get Judet views, you can see the same thing. He has a very small part of his radiologic roof intact, and then the rest of it over there. We can pose a question to the expert panel a little bit. Is this somebody that should have had attempts at closed reduction, and what's the likelihood of being able to get that? But maybe we'll save that for a few minutes. And Mark, feel free to interject or interrupt at any time you feel appropriate.
No, I think that's a great question. And how much roof is enough to where you would tell them yes, and how much roof would you look at on those x-rays and say don't bother, or just put them in traction? This would be though when the expert faculty actually turns their microphones on and chimes in.
I would say that as soon as you see the obturator to confirm the size of that fragment, you probably would be forced to the realization this won't reduce. So all you can do is pull it down while you're waiting for surgery, so that you don't do any additional damage to the articular surface on the femoral head. And that's because if you got to this early, but this guy's going to be 2 to 3 days out, the head's going to stay lateral, but the best you can do is pull it down.
So would you tell them not to even bother to try looking at this x-ray, Keith?
If I'd seen the original AP, I think the writing's on the wall. It's not that there's just not enough to hold the head. So multiple attempts, I can just sort of see cartilage disappearing with each attempt.
Yeah, so and I think that's a great message, but and the question is, do you try once or not? Our guys were just trained to pull on things, and they, and it's that series, which it kind of breaks your heart to see a little bit, but there's that series of about 4 or 5 x-rays all in a row, were labeled as post-reduction x-rays, or they keep trying, and then they take another x-ray, and they try again and take another x-ray, and it's too bad that we didn't get involved early enough to stop that. But
just to sort of on the other side of the question, I think if you see any sort of any portion of the complete roof shadow, even if it's attenuated, even with a very large or comminuted posterior wall fracture, there's usually enough roof to do a reduction and to keep the head in. In this case, we don't see any remaining significant roof shadow because it's all with the posterior wall. But a lot of times people will look at a comminuted, a large posterior wall fragment that still does have some roof shadow intact, and they'll say, oh, that's not going to stay in. And it's remarkable how little acetabulum you actually do need, though, to keep the hip in. But in this case, I would agree with Keith.
Okay, so good. So this is it's a posterior superior wall acetabular fracture. It's described by Letournel in his book, as was everything else that I think I've invented later on. And the difference is the ones that involve the radiological roof, as opposed to those that don't, are these posterior superior wall fractures. And again, I think the key point here is that most of these can be reduced. There's just some of these rare ones like this that don't really have anything remaining. This is just a single picture of his coronal CT scan, and I think it gives you the idea. You can see, again, what we were just looking at, if you can see my cursor here, but you can see how much of the actual roof is remaining here, and the head has just fallen into where there should be. The head should have, acetabulum should have followed along like this, but there's nothing there to hold this in place. I'll show you the CT scans here, and because I think they're interesting to look at, but I'll scroll through it. What you see here is the head riding up and it's into that defect where the wall used to be. And then if you look here, you can see that the entire dome of the acetabulum is to your left there, basically, and you can see how much is remaining in the actual acetabular fossa there. Just a very small amount of remaining dome of the acetabulum. So basically this took off the entire acetabular dome. And unfortunately, the posterior wall is very comminuted in the remaining portion as well. Just to show you the coronal views as well that we looked at one cut on, so we can scroll through that. And again, you can see the dome of the acetabulum up there, and you can see the head and the defect where the dome of the acetabulum used to be, and the small remaining portion of the acetabulum. And then finally the sagittal cuts, which I think basically again give you the idea of how far anteriorly this comes around. So if we look, when we get out toward the periphery of the acetabulum, you can see what remains, which is just that little tiny bit right there of articular surface. So any fixation that we put in, or any idea to see the anterior part of this fracture, means we're going to have to be all the way basically to the anterior inferior spine to be able to see that part of the fracture. Okay, so I'll show the 3D images for you as well. We've got multiple of those to look at, and then I think we can maybe stop and have some brief discussion about ideas from there. But again, you can see the dome of the acetabulum flipped out here. Here is basically the entire dome of the acetabulum out here, where far from where it should be. And again, just showing the amount of combination of the remaining posterior wall of the acetabulum. Just a cut looking at it from above, which I think it shows nicely. You can see the actual acetabulum here, and this is the big defect where it should be, and where the head was sitting while we were waiting for surgery. Okay, so maybe we could get our expert panel back involved again. And so this guy has an irreducible hip dislocation, currently with this multifragmentary posterior superior wall fracture. He's a 51-year-old guy. He's got significant comorbidities. He just had an exploratory laparotomy. He has significant blood requirements. Still has some hemodynamic instability. His lactate is still elevated significantly, and he is in the process of continuing his ongoing resuscitation. So he arrived at our hospital about 10:30 in the morning. He's had a laparotomy. It's now early afternoon when they finished with him. Injury happened about 8 o'clock in the morning. So I guess the questions that I think come up would be timing for his surgery, the approach that you would use, how would you get his head down? Do you do anything different to try to distract his head down into position so you're not fighting with that riding up highly? Patient positioning, fixation, and is there any role for a primary total hip? So Mark, I'll open that up for some discussion here, and then we can kind of go through what was done.
Sounds good. Why don't we start with the timing issue? So let's say this guy was cleared, and what's the urgency for intervening on his acetabulum? In this case, it's 10:30. He's not cleared. We don't know when he's going to clear, but let's say it was 10:30 at night with the same injury, or 5 o'clock at night with the same injury. Is this something that is needs urgent treatment before the next available OR in the morning?
So I'll see if there's anybody, if anybody wants to chime in here from our panel.
I think
It's Mike.
Go ahead.
Hi, it's Mike Stover. I think that there's really not a headache risk currently. The head is dislocated. It's I don't think there's a risk to the vascularity, and really there's not a potential wear pattern for the head with such a large wall. I think that it would be best to probably put the patient in traction and do the patient when he's medically stable and there's an appropriate team available to perform the surgery.
Keith, you were getting ready to say something. Was it?
Yeah, I mean, this is an unusual enough pattern that I would want to have home court advantage, which means I'd want the best people available and enough people, and that I could do it with a relatively low stress environment. So I definitely would not start this late. I think Mike's right. I mean, the wear pattern, I wasn't sure whether there was an impaction of the femoral head on that coronals or not. It certainly could be. The wear is going to be medial. If you're going to lose cartilage, that's probably the best place to lose it. But I think just skeletal traction pending the best possible logistical setup for whatever your institution is.
Okay.
So we could probably summarize by saying it should be done as soon as the patient is ready and you're ready, and that shouldn't be next week sometime, but it should be soon, but not in a less than ideal situation, and not on a patient who's medically or unstable.
Good.
All right, approach.
Well, so let me ask you, Steve, what's your limit for a prone coker in terms of anterior exposure, both for reduction and for fixation?
Yeah, so I think I don't know that I have a hardcore answer to that. The coker Langenbeck part doesn't bother me. We talk about doing a straight line Gibson, and people say that gives you better superior wall exposure. And maybe it does, but for me, I don't think that what I'm normally fighting is the skin, it's the abductor. So I don't know that where you place your skin incision or where you divide the maximus or whether you go anterior to the maximus makes a big difference. The real question is, when do you need to do a trochanteric osteotomy or something to give you better exposure? And I don't have a hardcore answer. I can tell you that just in my own sort of anecdotal brain, I've kind of come up with the idea that if I think I need exposure or fixation that's higher than the roof of the sciatic notch, or that's beyond the 12 o'clock position on the acetabulum, if looking at it as a clock face, then I start thinking about how that I have some concerns about seeing the extent of the fracture and considering other types of approaches or extensions of approaches.
You say higher than the roof of the sciatic notch in terms of the posterior wall, or
Yeah,
fractures that go above the roof of the greater sciatic notch?
I would say as far as the posterior wall, yeah.
Okay.
For extension, that I need to see higher than that. Yeah, referring to wall fracture, sorry.
Other faculty members want to comment on approach?
Yeah, I think that the point that Steve made in terms of the cranial anterior extend is very good. I think when I'm starting to look at the CT scans, anything that with the fracture line, again, getting more cranial, more anterior, like over that 12 o'clock position, if it's more than 2 centimeters plus over the head, that's just the apex of the fracture. And then I'm worried about getting some sort of fixation, plate fixation to be on top of that. And so it makes me want to think about something else as well.
Yeah, it's not only that even if you can see it, what the worry for me is that I'm stretching so hard that I'm going to be doing damage to the superior gluteal nerve and possibly artery and vein as well.
Agreed.
I would think the other
I think
thing
also in this circumstance, I think the position of the wall fragment anterior to the head in a prone position would make it very difficult to even retrieve that fragment prone, because it'd be hard to mobilize the abductors sufficiently to get that back and over.
Yeah, I think that's a key point. It's that anterior fragment is rotated 90 degrees. And so you have to be always cognizant of what your technique for getting things that are anterior to the head. I think if you pull this down with traction, your access to that fragment will be better. And we're hoping that there still is a capsular pedicle on it, but there will be times when this is an entirely free fragment that you can't take advantage of that pedicle whatsoever. So, and if you're prone and there's something anterior to the head that you can't get, then that's end game, and you're going to have to re-prep and re-drape in a different position. So I think it's part of the key part is when these multi-fragmentary, is that you have a full inventory of all your fragments, and you have a strategy for being able to get to all of them, and then make sure that you account for them intraoperatively. So at the end of the case, you don't end up with something that's missing. I mean, your access into the joint is enhanced by the size of the wall, especially posteriorly. And so you don't have that issue, but stuff in front of the joint is a huge problem, or at least it can be.
Okay, so that's all great points. So yeah, so for me, I felt like I needed to be lateral for the reasons you say. And I'm always concerned. I don't like doing Coker Langenbeck's in the lateral position if I have a choice, just because I feel like the patient flops back and forth so much the way I position them that I don't feel like I can maintain sterility posteriorly as well. So given that, and given the concerns about being posterior and superior, we chose to do a Gibson approach. So he was actually not stable enough to go to the operating room until the next day, and it was not able to be cleared in time for the first case. He was actually done about noon the following day. That's when he was taken to the operating room. Did him in the lateral position. As far as getting the head down, I thought that there would be some advantage to having something to help pull it down. So we actually made some makeshift traction. We put him in a lateral position, put a big stack of towels under his knee to abduct his leg some to try to make the head seat into the acetabulum, and put a distal femoral traction pin in with the rope that we threw over the end of the bed, over a device we had at the end of the bed, to try to give us some makeshift traction. I did a Gibson approach for the trochanteric flip osteotomy, and used buttress plates to try to get our fixation. And I'll show you.
Right, Steve, so logistically, is the leg prep free here?
Yeah, the leg is free. So we have, it's completely the leg is in the sterile field and free. And,
okay, how did you manage the prep? I mean, guess what I'm thinking, but yeah.
Yeah, how do you prep the leg while it's in traction?
Oh, well, it wasn't in traction. So we prepped it out of it. We prepped the leg completely sterilely. We had a traction pin in distal femur, completely prepped the leg free, and then hooked a traction bow, sterile traction bow onto the traction pin. We have sterile rope that we tie to the traction bow, and then we threw that off. We had some of the old OSI traction stuff on the end of the bed that we can throw something over the end of it. So that was actually just thrown over the end of a bar at the end of the bed, and then weights were tied on that at the end of the bed.
I guess my concern is always during the prep, what's happening to the head. So this is one where I would bring in do a cross table PA and find out where the head is at the beginning. And usually if you put a little bit of traction and quite a bit of abduction, the head can be made to seat, and then with external rotation, you're depending on the anterior hip capsule as a check rein. And if you hold it in that position, it usually requires 2 people to prep because somebody's got to hold it. And I think you can minimize the potential for additional soft tissue injury. And maybe it's not that much, but the prep is very difficult for these, I think, because it's the head's moving around, and sometimes you can hear things you don't want to hear in the process. So
I will tell you that I did hold his leg. I do hold the leg for things like this myself while somebody else preps it, because
yeah.
I don't think I'm holding it reduced, but I just feel like I don't like to walk in the room and see them with the usual thing where it's externally rotated and somebody's basically pushing on it. Additionally, it makes the approach a lot harder. I don't know if you've tried to do approach to the hip with the hip dislocated, but when the trochanter is not where it normally lives, when we use that kind of for our guide for the approach, it makes it a lot more difficult. And when it's lateral to where it normally is as well, it makes the approach a lot more challenging. So something to think about when you're doing it. So we did do the Gibson, the modified Gibson approach, basically with a straight line incision. As we said, I think it might give you some advantages for the supraacetabular area. It gives you pretty much the same retroacetabular access as long as you keep the hip extended, but very limited access, I think, to the to work within the greater sciatic notch. Did the trochanteric osteotomy and did not do a surgical dislocation, just the osteotomy to give us visualization. And you can see in this, maybe you can tell, but this is actually the anterior inferior spine, basically right here. So you can get access and plate fixation all the way around with an osteotomy like this. You need to have some ideas how you're going to do distraction. We did it with traction, but you can do it with a fracture table, or you could do it with a universal distractor with pins in the pelvis and in the femur to help pull that down if you wanted to. The disadvantages of these things we've talked about already is that you don't have a free leg to be able to manipulate some. So I'll just kind of go through the case a little bit with the C-arm images that we had. You can see how we were able to get the head pulled down reasonably well. It's not all the way down, and to get it to seat fairly well in the acetabulum. I think that's important because it's hard to get that wall piece to sit back in place when it's the entire dome of the acetabulum, when it's, if the head is riding up superiorly. We've been able to kind of push this back in place and put a couple of K-wires to hold it there. And then from there, put these little buttress plates to try to help complete the reduction. You can see it's still gapped a little bit there, but these screws are here and here are just at the superior edge of the acetabulum. We put the little 2-hole plate on first just to trap that fragment, and then we put one down that came down a little bit further down onto it with the idea we'd close this down. These we leave in place, and they actually do serve as a real buttress plate since we're trying to resist that shear component going superiorly, just like you do if you turn this upside down and thought about a tibial plateau fracture. Once we did that, we added our
Steve, particularly with the comminution that you have of the inferior posterior wall, it'd be really easy to have the femoral head still be sitting a little lateral, and the superior fragment would look reasonably good, except on an AP X-ray, you'd see a gap in the roof. And I think you saw that initially on some of your earlier fluoro shots.
Yeah, you still see just a little bit there, I think, too. It's a little bit lateral, and you can see a little gap there as well. We're hoping to close that down with lag screws and with the final buttress plate that we put on top, which I think we basically did. But you can see the additional buttress plate here, and there was multiple fragments of the posterior wall inferiorly. We were able to get one piece big enough to kind of get some fixation into and put a lag screw into that as well. Added a second plate, and basically just kind of corralling all of those other posterior wall fragments beneath the plates to kind of keep them in position. And this is kind of what it looks like at the end. And I'll go back just to show you that, again, I think one of the points is you can see how we're able to get our fixation. This wall fracture comes all the way out to here. So we're able to get fixation beyond that. And to do that, it really requires the screws that go almost all the way to the anterior inferior spine to be able to get that, actually trap that fragment beneath it. And I think that'd be very difficult to do through any other type of exposure other than maybe with a trochanteric osteotomy. These are his post-op x-rays, and I'll apologize because I think they're really ugly x-rays because there's so much metal that it kind of overbears everything, but I'll just show you the post-op films. This was him coming back at 4 months. He's still he's one of those guys, every time he comes to clinic, I hold my breath and hope that he's not dislocated again. And this is him at 14 months out. This was the last x-rays I have of him. You can see his hip is not normal, but hip remains congruently reduced. And he's actually got fairly good function. You can see the iliac oblique view and the obturator oblique view as well. So he is, I have about 4.5 year follow-up on him clinically. Almost, I think the last office visit he had, he goes to see his primary care doctor because of all his multiple medical problems. He sees a cardiologist regularly as well. He's actually got good function. He walks with no assistive devices. He takes an anti-inflammatory occasionally, but that's for a rotator cuff tear that he has, not for his hip, and has not had to have a hip replacement in that 4 to 5 year interval since from a clinical standpoint. So take-home points, posterior superior wall fractures are challenging. They have much higher failure rates in the literature. You need to consider an approach modification that will give you adequate visualization to see the anterior and superior extent of the fracture so you can actually see the fracture margins. A modified Gibson or Coker-Langenbeck approach with a trochanteric flip osteotomy is safe and will give you supraacetabular access that you can't get safely through other approaches. And additional fixation with true buttress plates may help improve the outcomes with this group of injuries. So that's it, Mark. I'd be happy to take any questions or
Hey, Steve.
points. Yes.
Do you have any points or keys that can help us extend the exposure through the Gibson? I know that Roy Moe talked about extending it all the way up to the iliac crest or even peel the little anterior, especially when the patients are kind of, especially if you do it prone, but in a lateral position, to find it a little tight sometimes.
Yeah, so I agree. I usually do make my skin incision just because I guess I'm more of a trauma guy than a reconstructive guy. I tend to make my incision all the way to the iliac crest. So I make a longer skin incision. I don't normally take the gluteal sling down, but I guess you could consider that. But I think the real key is to keep the hip in extension. So any flexion of the hip at all tends to really tighten those posterior structures and makes the retroacetabular surface very difficult to see. As far as seeing superiorly, I think that's just continuing to free up across the anterior capsule and working anteriorly enough to be able to really mobilize that sling with the digastric piece of bone attached to it. I think hip extension, though, is really important and really keeping it extended the whole time.
Steve, why don't you go and unshare yours, and Phil, you can start sharing your screen while we see. DS, were there any more questions in the Q&A to address to Steve?
No, there was a few questions about whether an extended iliofemoral would be useful in this case, and I think that that's really not going to provide any advantage with significant morbidity, as we heard about, compared to what was done here with a Gibson and a trochanteric osteotomy.
Yeah, I think I would agree. It certainly would give you the visualization you would need, but at a much higher cost.
Great, thank you. All right, we'll turn it over now to Phil KREGOR from Nashville for his case.
Good morning. It's really nice to be here. We're very sad that the OTA won't be here, but we're going to bring you a little piece of Nashville this morning. This was Nashville at 8:30 on a Friday night. I had just finished the OR for the day. I was walking down the hall to leave the hospital, and just kind of nonchalantly, the general surgeon said, "Hey, Phil, I just finished an X-lap on a lady. She's pretty unstable. I think she has a pretty significant pelvic fracture and some arm fractures, room 8. And I happened to be passing by the radiology technician with the machine, looked at the X-ray, and saw this. So this is our case for this morning. She's a 21-year-old female. She had a motor vehicle collision. She was brought within about 10 minutes from the ER to the OR for an emergent laparotomy for a pretty significant splenic injury. Her lactate was in the 4 to 5 range. She was on the table when I got that message. Her BMI was about 42, and she was noted to have a pretty significant posterior right buttock soft tissue contusion. Oh, by the way, she had about 3 to 4 centimeter open bilateral humerus fractures. And this again was her AP radiograph that they actually had obtained for a sponge count after their emergent laparotomy. And I think it's really good to pause and just say, what information are we really seeing on this AP pelvis? So the first thing that I think is pretty noticeable is the femoral head is medialized and not under the articular roof. You see some impaction of the radiographic roof there. And then I think a good clue, and it may not project so well on your computer screen, but there's an inferior ramus fracture on the contralateral side. And I think you can see pretty nicely that there is a left SI joint injury. The other thing that I notice is that the right innominate bone, or the right iliac wing, is externally rotated. If you look at it in terms of the spine, that's a pretty good AP radiograph. And we're seeing more of the iliac crest on the right side. So this shows that there's some external rotation of the right side. And oh, by the way, she has some femoral acetabular impingement, which is asymptomatic but radiographically apparent actually on both hips. So like most of the times, the AP pelvis gives us a lot of information. It's 8:30 at night, and oh, by the way, there's also a small cortical break in the superior aspect of the ischiopubic segment near the greater sciatic notch. So there it is, she's on the table. The general surgeons tell me, look, she's pretty unstable, but if you need to do something that's absolutely necessary, please do that, but be quick about it. And don't really have the best, certainly orthopedic trauma team at about now 9 o'clock in the evening, but could proceed with anything that you feel is really urgent. So I felt some of the priorities were to, in fact, while they were closing the belly, I prepped out the arms relatively quickly and debrided the arms and put some splints on. And then the question is, what are we going to do initially with the right hip?
Phil, did you have the did you have a chest, abdomen, pelvis CT from a trauma assessment, or had they gone right to the OR without it?
Yeah, there were no other injuries, to be honest, Mark. I don't know whether that, I can't recall whether or not they actually got a chest CT and abdomen CT. I think that it's a very high likelihood in our institution that that was obtained in the first 5 minutes. Yeah.
Yeah. So just wondering if you also had some CT information about your pelvic injury available to you.
We did. We did have some information, and I can show you that CAT scan. Quite frankly, things are moving a little bit quickly because they really want me to get out of the room. And so, you know, that's why I think I make the point of really using all the information on the AP pelvis. I probably scrolled through the CT scan very quickly. I don't really recall. It's been over about 15 months now. So the question is what are we going to do initially? I'll just kind of back that up to you, Mark. What are your thoughts here in terms of, I took care of what I thought was urgent in the arms, and the question is what to do with the right hip. Yeah,
absolutely. So I'm sure that the comments from the faculty will be try and get the hip reduced, and you know, while she's paralyzed or still hopefully intubated, to be able to do that. She's obviously not going to be stable for any more significant intervention there, but there is some posterior pelvic ring injury, and that's why I was asking about the CT, because an understanding of the posterior pelvic ring injury, if the patient was a little more stable, maybe there's something you could do to set up your next surgery a little bit potentially.
Yeah, And I'll tell you, this is real life. She's also on a regular OR table, which I'm not too proud of, but
that's a daily occurrence.
Yeah, and so certainly we could have switched her to a completely radiolucent table, but this was a X-ray taken underneath the patient, and we don't have a radiolucent table. She's pretty unstable. I think that what I pointed out before, she has bilateral SI joint injuries and no other abnormality. And my initial management was, as I said, debrided and splinted both of the open humerus fractures. I attempted to reduce the right hip. I was hoping that the femoral head would go underneath the radiographic roof. That was not a satisfying thing. And I also placed her in distal femoral traction. And this was the intraoperative plain film. And I think we have another film that just documented that when she got back into bed, she was at least not wedged in between the transverse component of the fracture. Maybe John Eastman might comment. John, Dr. Eastman, what do you think here? Are we okay here for the time being to live through the night, so to speak?
Yeah, Phil, I think this is very much similar to the first case that Dr. Sims mentioned, in terms of this patient is not hemodynamically is hemodynamically unstable and is not ready for any sort of intervention. I think with that medialization, you know, I think I tried to make the point in my lecture about the combined pelvic ring and acetabular fractures, where you're looking at the SI joint and how that the left SI joint is tethered through the symphysis, which is now onto the ischiopubic segment, and that's somewhat tethering that head back down through the ligamentum into that position. And also with the right sacroiliac joint, it really can't get back out underneath that intact dome. And so I think, you know, you had mentioned that she is on unfortunately on a regular non-radiolucent table, but in that femoral head position, that's probably the best you're going to get, which I think is acceptable. But I think if possible, I would love to consider getting her into some sort of circumferential wrap and or an anterior based external fixator to close her pelvic ring, which will help with hemodynamics, but then will also help with reestablishing her dome on the right side to where it's supposed to be in space. So that way her head can now get to where it needs to be and sit there.
Yeah, I think those are great points, Dr. Eastman. So she recovered. We studied, just to Dr. Reilly's point, this is the CT scan. So the answer is, Mark, we did have a CT scan, now that I look at this, prior to going to the operating room. And these were asking for some reconstruction cuts. And there you see a pretty significant left SI joint injury and some mild right SI joint injury. And please keep in mind that there's a gantry effect. So probably based on the AP pelvis, I would make the argument that the right side is also more injured than is represented on this CAT scan. And here's a 3D reconstruction, again showing the left SI joint injury, the pubic root fracture on the left side, and then what turns out to be a transverse fracture. And you'll notice there that there's a cortical fragment at the superior aspect of the ischiopubic segment. There's a 3D reconstruction of the posterior aspect. You'll notice there is no posterior wall fracture. We did not obtain true Judae's films here because this is a case where I would be concerned about what happens to the femoral head if one was to try to get Judae's. And so what we're really talking about here is acetabular fracture with associated pelvic ring injury. And my goals are really to discuss how an SI joint injury affects the ease of reduction of a transverse fracture. I think that's an important point. Then to understand the surgical tactics for reduction of the transverse fracture in such a situation, and think about the options in terms of sequence and positioning for such a situation. So just going back to some of the things that we've learned in the past weeks, we've learned that a transverse fracture usually is addressed from a standard Coker-Langenbeck. Occasionally, especially with pelvic ring pathology, we might utilize an ilioinguinal approach or the interpelvic anterior approach, and very rarely an extended iliofemoral approach. So going back in terms of the Coker-Langenbeck, we'll remember that we utilize distal femoral traction, distraction of the hip joint. We can use an ischial tuberosity Schanz pin. We can use angled jaw clamps and other clamps through the greater sciatic notch. And we can also use the so-called screw-to-screw clamp family, namely the Faribuff and the pelvic reduction clamps, as is seen here schematically from a Coker-Langenbeck. But going back to our case, we recognize that there are some complicating factors if we have a transverse fracture, and those include an ipsilateral or contralateral SI joint injury, a sacral fracture, anterior ring pathology, and certainly the transtectal pattern. So this is our situation after the patient is in skeletal traction. And so the diagnosis is that of a transtectal transverse acetabular fracture. We have both a right and left sacroiliac joint injury. We have a left superior and inferior rami fracture with the pubic root being involved. And we also have a small amount of articular impaction at the transverse fracture. So what are our options? Well, certainly one could go through a whole list of options, but I tried to list here, I think, all of the potential ones, and then I thought we could open it up for a few minutes for the faculty to kind of discuss through that. I think that one could do either supine or prone iliosacral screws, and then perform a prone Coker-Langenbeck for a right transverse fracture. The second option might be a prone Coker-Langenbeck for the right transverse fracture and then iliosacral screws. A third option might be supine iliosacral screws combined with an anterior approach to the right acetabulum. And then finally, open reduction of the SI joints with an anterior approach to the right acetabulum. So let's just think about concern with iliosacral screw placement first. I think the problems that I can get into is how do I know that the SI joint is perfectly reduced? I think perhaps that, thinking about the left SI joint, one might make the argument that if you were going to use just an iliosacral screw, that an intraoperative CT scan, if available, would be helpful. And then the question is what if the SI joint is not perfectly reduced and you are trying to reduce the transverse fracture? How do you deal with that? Conversely, let's think about fixing the transverse fracture first. Does external rotation of the left hemipelvis allow for appropriate reduction of the transverse fracture? And will prone positioning make external rotation of the especially left innominate bone in this case worse, and therefore make the transverse fracture harder to reduce for the reasons that Dr. EASTMAN already talked about? And how about the question with the left pubic root fracture? Do the SI joints even matter because you have so much laxity in the pelvic ring? So I'd just like to maybe get some of the other faculty's opinion in terms of surgical sequence and positioning. And I'd like you to break it up into that. First, what are you trying to address first? And then secondarily, what position are you going to start out with and what position are you going to go to? Maybe some of the faculty could comment on that.
Phil, while they're getting ready to chime in, there was a really good question from a participant that occurred to me as well, which is that should you image the superior gluteal artery vein with an angiography or a CT angiography preoperatively to know whether or not it's in the fracture before you choose your approach for the transverse?
So my read on this particular fracture, and we could go through the 3Ds as well and the plain films, is that while the superior gluteal is at risk in any transverse fracture, I suspect with the displacement, I didn't read this as one that was would be commonly involved. So I don't think for me that that's going to affect the surgical approach. You will recall, however, that she did have significant soft tissue abrasions, contusions about her buttock, and that her BMI was 42. I think those are two soft tissue concerns. I think it's always good to think about the superior gluteal, but at least me personally, that's not something that I would get an angiogram on in this particular pattern.
Okay, other faculty members, comments on your surgical sequencing?
I'll take a stab to start it off with. So I think your ability to reduce that transverse fracture on the right side with the SI joint gapped open on the left is going to be, and displaced, is going to be nearly impossible. Your point is good that there is a slot point in the front with that ramus fracture, but I would be willing to bet there's enough good soft tissues attached to that that with that SI joint being that far off, you will not get that transverse fracture reduced. So I would probably do an open reduction of the left SI joint, and I probably would do that first. And I mean, you could do that anteriorly or posteriorly, but I probably would do it anteriorly for the reasons you said. And then I think what you're left with is the left side, and that SI joint. Again, look, I don't have all the x-rays to look at, but the ones we saw, it looks to me like it's just gapped a little bit anteriorly, which I think happens quite a bit with these transtectal transverse fractures when the head goes inside the pelvis like this one did. It's almost like the head is forcing it out. And so for me, for those, I tend to address the acetabulum next. And I probably, whether I would do that supine or and you do anterior or prone, I think depends a little bit. I didn't see how clearly that quadrilateral surface was broken, but that adds a lot of complexity to it, because that's kind of where, if you do it from the back, that's kind of where some of the clamps go. And if you're doing it from the front, that's how you judge your reduction a little bit, So my preference would be to do an anterior SI joint on the left side, then flip her over, do a Coker-Langenbeck, and do the acetabulum second. And then if I thought I needed to do something to the SI joint on the right at the end, I'd do that last. And then maybe, I think at the end, I'd make a decision whether I thought that ramus needed anything added to it or not. But if it did, it would just be a screw or nothing.
So Dr. Sims, I think that's a really logical sequence for me, but I'd just like to push you on a few things. The first one is, what has been your experience if you would turn this patient prone and do a Coker-Langenbeck and say, I'm gonna, because we all agree that the acetabulum is the most important thing. If you turn this patient prone and say, I'm gonna do the transverse fracture first through a Coker-Langenbeck, what's gonna be the situation? What do you predict?
Well, I suppose you're getting are we going to make the SI joint worse and make the ramus worse on the other side? And I think that certainly is a possibility. Again, I think of it almost like a ring, though. It'd be like if you close the symphysis, the SI joint tends to close down in the back. I think if you close that acetabulum down, which I think you could do with clamps, that the SI joint would close down, and then you can decide if you think you need to add fixation to it or not. But your point is good, and you have to show me that quadrilateral surface again. I'm not sure how well you could judge the reduction. You'd be judging it. You have a big surface area posteriorly, but you only have your finger to feel on the inside. and you have to place clamps to the notch. And if that, I didn't see how much of that quadrilateral surface was broken, but if it's a lot, that might force me to want to go from the front.
Yeah, it's a lot, and I guess the point I was trying to drive home, which I agree with, and what you said is, I think if you put this patient prone first, the significant external rotation of the left hemipelvis is going to make it very difficult, if not impossible, to reduce the transverse fracture.
No, yes, so I said I would do the left side. I would do first. That would be the first thing I would do, and I would do that supine. Yeah.
Right. Yeah, I'm agreeing with you. But the second point is why not just put in an iliosacral screw? I mean, Dr. Rout and others have really shown us some very nice cases where they get really nice reductions with a percutaneous screw. What are your thoughts on that? I heard you go completely to an open reduction right away.
Well, I think that if you can get a good reduction and you're sure of that, you know, if you could, I guess you could put a Chance pin in the anterior inferior spine. You could try to rotate it, and if you felt like you could get a good reduction, you could consider that. In my hands, I'm not as adept with doing that as some others are. So I would tend to want to see this and make sure I got it right, because having this off is going to really complicate your ability to get the ischiopubic segment on the transverse fracture is going to tend to follow the left hemipelvis. And if it's not reduced just right, I think you're going to have a hard time, even with that ramus fracture in the front, it will complicate your ability to reduce that transverse fracture.
So if someone were to say, I'm going to start supine, I'm going to put an external fixator on, and then I'm going to stabilize both sacroiliac joints because the rami are going to be a relief point, do you think that that's a sufficient reduction of the pelvic ring to allow you to reduce the transverse?
I don't know the answer to that, but I think it would be hard to get that right side reduced well, even with an external fixator with the head where it is.
Yeah, and I think that's the point is that we don't know, right? You can give it a try and hope that the ramus gives you enough slop to reduce the transverse, but until you start trying to reduce the transverse, you won't know if your pelvic ring malreduction is affecting you. And if once you find out that it is, you got to start over from scratch.
Agreed.
I think that's a really good discussion. So the thoughts that went into my mind and the issues were, number one, a relatively large cortical fragment that was mostly anterior on the superior aspect of the ischiopubic segment. Number two, the left sacroiliac joint. And number three, her body habitus. And number four, the relatively large posterior contusion on her buttocks. And so what I did is exactly actually what Dr. Sims talked about. So an open reduction, you can see there, that's a open reduction along the internal iliac fossa, seeing the L5 nerve root. And there are two plates across the SI joint, which was first reduced with a screw-to-screw clamp and with aid of a Chance pin in the iliac wing there. And then for added stability, I placed an iliosacral screw. And then we went to the transverse fracture through an ilioinguinal approach on the right side. And you'll recall that Dr. Reilly asked me the question, on a typical transverse fracture, why do we normally go with a Coker-Langenbeck? And the answer that I gave is our ability to reduce a transverse fracture is generally easier. Our reduction tools are better from posterior, and it is challenging in a case like this for me to reduce the transverse fracture, not impossible. But the continued concern is peripheral gapping posteriorly, and is also in dealing with working around the iliopsoas in a patient who's relatively large with a BMI of 42. And then in this particular case, the concern is the separate cortical fragment superiorly. So these are some of the tools that can be utilized. You see a screw-to-screw clamp there, more peripheral around the transverse fracture. And we also utilized a short angle jaw forceps. And you can also see that we have a Chance pin in the proximal femur. And we're certainly challenged because of the separate cortical fragment here. This is a actually out of sequence film where I actually had to take out that screw. You can see that's a malreduction, and we certainly had several iterations of the reduction attempt. But in the end, we did what Dr. Sims talked about, which was to first do an open approach of the left SI joint, address the right acetabulum through an ilioinguinal. You can see there's a separate cortical fragment there superiorly. And then we placed 2 additional plates across the now minimally displaced SI joint. And you can see, you know, if you have things correctly reduced, then our rami fractures on the left side should be minimally displaced, and they are. But you can certainly see here, this is the problem, at least for me, for a transverse fracture, is that we can have some peripheral gapping, especially posterior. But there is the situation in terms of the reduction on both views, the initial postoperative view. And there's the postoperative CT scan demonstrating an appropriate reduction of the sacroiliac joints and the transverse fracture. Really open it up for any critiques, suggestions, or comments, but this is the patient at 1 year follow-up. Fortunately, and pretty impressively, she's lost 40 pounds, mostly because of exercise, I'm told. She's able to jog, but she did have a need for a pretty significant debridement and skin grafting of degloving injury in the right buttock. So in conclusion, let's just remember that SI joint injuries and sacral fractures and anterior ring fractures significantly complicate transverse fracture reductions. Transverse fractures can occasionally be treated with an anterior approach, especially with multiple pelvic ring injuries. There may be an advantage to supine positioning with an anterior approach, if the acetabulum is possible to be reduced with simultaneous exposure of the SI joint. And just like from posterior, we're going to utilize the short angle jaw forceps, screw-to-screw clamps, and Chance pins as common reduction tools. Thanks very much.
Well, that looks great, Phil, and thank you. I think that it's great that she's doing well. If you go back and think about that 3D, boy, I think that would be a real challenge to get that transverse anatomically reduced with the large quadrilateral surface segment of comminution removing the vast majority of your reed. It's going to be difficult either from an anterior approach or a posterior approach, but a nice job there. Any thought too, I know Mike Stover's shown a case before where with the anterior approach, he placed kind of some flexible fixation to improve the reduction of the transverse, but then flipped over and did a coker. Now, obviously she's got contusions of the buttocks, she's large, but to then complete the reduction of the transverse from posteriorly.
Yeah, I think that's an intraoperative audible that the surgeon should be prepared to make. I think that the peripheral gapping, I think your point is really well taken, because although I show a reasonable 1 year result, that is not a perfect reduction of her acetabulum. And I think probably we could have improved that with a prone Coker Langenbeck. My judgment in this particular case was, although not perfect, pretty close, within 1 to 2 millimeters. And I did not think with her body habitus and the soft tissue contusion that was wise for her given case. But let's remember she's 21 and we want it as perfect as possible.
No,
I think from a standpoint of a similar injury, though, that idea is very important, Mark, especially if you have a ipsilateral SI joint and a high transsectal transverse with an extended posterior wall. I think that technique can work quite well because you do have a better ability to reduce the anterior limb of a transverse from the front if you have an extended posterior wall associated with it. So you can start supine and then go prone for that kind of a case.
And by more flexible fixation, you mean just like a 3-5 screw across the fracture?
Yeah, typically just a 3-5 screw down the anterior column in a lag fashion that hopefully get a little compression on it.
John, why don't you bring yours up? Any questions, DS, from the participants that want to direct toward Phil? He's been cranking out the answers here.
Sorry, no, I think everything was addressed with the discussion in Phil's presentation.
Okay, we'll turn it over to Dr. Eastman, who's going to present what will probably be our final case of the morning session.
Okay, thanks, Mark. And so we'll start with just some objectives for this case. I think the importance of really hitting home all the points of truly understanding the diagnosis will kind of set you up for success and plan based up all the subtle details of where you're going to be able to see and sequencing of your reduction fixation, I think is paramount. And so I think the main point we'll be discussing here is the optimal strategies for each patient and injury in terms of addressing the marginal impaction that we can see. And so our patient here is an 84-year-old with some medical problems as you see listed, primarily I think with his heart, hypertension, and then some dementia. He had a ground level fall with some isolated left hip pain. He is stable otherwise, but here's his injury, AP pelvis in the ER. And so you can see there's been a disruption of both the ilioischial and iliopectineal lines. You can see extension of his anterior column fracture line extending up onto his iliac crest. We're already getting a sense of some comminution on that quadrilateral plate and working down the posterior column. And then as we look through his other series of the 5 views of the pelvis that were obtained, you can see a large segment of dome impaction that we can see here. And so looking through both his Jude views as well, you can see that same segment of dome impaction. And then just some very select CT cuts. Again, you can see the displacement of the iliac crest. That arrow in the top middle picture is pointing to what I'm considering to be some intact cartilage. There's no continuation of the fracture line that fully goes out the posterior acetabular surface, but we're going to see under intraoperative imaging that maybe that cartilage isn't truly intact. And I don't think it's semantics. I think really understanding the fracture pattern and some of the very subtle differences between the associated both column and the anterior hemitransverse or real need to be appreciated. But then again, we can see a large segment of the cranial dome impaction that we can see here. And just some select CT scans of surface rendered images. We can again see what we saw in our AP pelvis with the extension of the anterior column going up. We can see that it's somewhat incomplete on the internal iliac fossa. And then looking at our Jude views, again, we can see some of the details. And again, just highlighted because I think the focus we like to discuss on this case is that large segment of dome impaction and how to best deal with it. And so I think it'd be great just hit home with some of these points and maybe get some faculty input in terms of the diagnosis. Initial treatment, I think we've talked about with some of the other patients today in terms of the role of traction, and then start talking about a sequence in terms of surgical approach, and then really how to deal with that impaction. Mark, do you want to make any comments or questions?
Well, I think that the first question obviously is going to come up. Is this patient an amenable patient to internal fixation, to weight-bearing restrictions post-operatively, to post-operative compliance? Is he a surgical candidate? And if so, is he a surgical candidate for internal fixation or arthroplasty or a combination of both? And how do you decide in an elderly patient with multiple medical problems, including dementia?
That's a great question. I'm happy to take that if any of the faculty wants to contribute.
Are there any fracture pattern characteristics where you look at it and you say, oh, this is definitely more of an arthroplasty consideration, or is it just patient related?
I think I'll go first. I think that it's the whole picture. I mean, I think the patient itself comes into play in a big part. I mean, if someone, I think age is just a number, and if someone is chronologically old but physiologically young, that's a much different picture than someone who's younger but with a whole host of comorbidities and functional levels that go along with that. And so I think that comes into play, but then also all the fracture patterns that we've talked about in terms of impaction, femoral head damage, comminution, all those things come into play in terms of whether you can truly obtain an anatomic reduction. Then also, even if you can, what's the longevity of the cartilage that's underlying that, and is it viable? And so there's been studies that have looked into prognosing or making a prognosis for those patients, trying to get some sort of idea of predicting the risk of post-traumatic arthritis. But again, I don't think that's the most accurate tool. And I think every time it's putting all those pieces of the puzzle together to try to come up with a patient-centric decision for that.
Yeah, I think if you were to look at the nomogram paper that Marius Kiel wrote up, this patient is going to be a very high risk for post-traumatic arthritis. But for me, I think some of the important factors, Mike, maybe you can mute yourself for a sec. Most important factors would be femoral head injury, femoral head damage, and then also the nature of the impaction. In your case, it appears to be a very large single impacted segment, which is potentially a much friendlier situation for reduction than the situation of the same volume or the same surface area of impaction, which is in multiple fragments going in different directions. And we oftentimes will see that situation as well. I find that a much more difficult situation to obtain a reduction and to also maintain it. Other thoughts from the faculty?
Agreed. Very good points.
Yeah, I think that's a good point, is that the ability to obtain it is one thing, and then the ability for it to stay in place, especially in these osteoporotic individuals, is another one. I think it's very challenging to keep that in place with a patient that's demented and unable to follow post-operative protocols. And that's typically an indication for me to look towards arthroplasty if I think that the patient can tolerate that.
The other factor is the size of the anterior column component. So this one is incomplete. It looks like one of the extensions is into the interspinous notch. And the smaller the anterior column component becomes, to the point that's becoming an anterior wall, the less available real estate you have for stable internal fixation. And at least my experience with anterior wall fractures in older patients has been miserable, especially when they're associated with marginal impaction. So if you got a big anterior column that you can make stable, which is going to buttress your marginal impaction segment, I think that's a favorable factor. But the closer you get to the joint with the anterior column, the worse the outcome, in my experience, at least.
For me, this is a situation where I think, you have to be cognizant of how long you're going to be in the operating room. And, you know, sometimes I've made the mistake of saying, well, I'll treat it like sometimes a proximal humerus, maybe try to fix it. And then if that doesn't work, go to a total hip. And the problem with that is just timing and the OR sequence. So for me, the question is always, what's the predictability of this being able to, as Dr. Stover said, maintain the reduction? And I think it's been helpful for me to, prior to the surgery, say, I'm either going to go for a fixation or I'm going to go for a fixation of the anterior column and the quadrilateral surface, and not mess around with the articular surface and immediate go to a total hip. Because I think this is a situation, and I don't pride myself on being a fast surgeon, but I think this is a situation where you know, at least in my mind, a 2 to 3 hour surgical intervention is the most that reliably you can do without getting into significant medical issues.
So Phil, would you be in favor of more of a Levine approach, some internal fixation and then a anterior total hip?
The answer is yes. I think the older I get, the more I like predictability. I think that it's going to be the most predictable route. Though certainly I have, you know, I usually tell patients with this particular fracture pattern, there's about a 20% chance that you wish I never walked through that door. And I say that to the family and to the patient to just have them understand that this is a pretty big deal. So I certainly have cases where I've done a Levine, fixed the quadrilateral surface, fixed the anterior column, put in a cup, and the cup is loose. In fact, I just saw a patient yesterday, but I still think it's probably the most predictable in this particular pattern.
I think another option to present would be the possibility of a supine anterior intrapelvic approach, some type of a quadrilateral surface buttressing implant along with an internal fixation of the anterior column, followed by a more either standard anterior or posterior, for that matter, total hip, either same setting or another setting. All right, John.
Yeah, I think those
Mark,
are all.
before we leave this, let me just ask the one cursed question that nobody will bring up. What about treating this non-operatively in a patient like this?
I think it's been established pretty well with some recent papers that the elderly with these types of fractures, they do not do well in terms of their morbidity of being bedbound and not being able to mobilize. You know, whether with or without traction, it frankly doesn't matter. They're tied to the bed either way. And so I think some sort of intervention, I think, is warranted. I mean, I think we kind of simplify it that this is just like a hip fracture in the sense that it's just the other side of the hip. And I don't think there's a lot of people considering non-operative treatment for elderly femoral necks or intertrocks. And so I think we're fairly aggressive, appropriately aggressive in terms of trying to get some sort of treatment plan so that these patients can avoid the problems with prolonged recumbency.
Well, for me, hi, Dave Stephen here. For me, if you elect to treat this non-operatively, this is a case where you mobilize protected weight bearing with a walker, and you don't keep them in bed. You get them out of bed, at least bed to chair for sure. And then you get into the consideration whether pain is an issue, and that's obviously a relative indication. But, you know, if you decide that for comorbidities or complexity related to post-operative management, then this would be a case that you'd mobilize. And obviously the x-ray is not going to look very well, but I'm not advocating that. I'm just saying that if you choose non-operative, that would be the algorithm.
David, have you seen many patients being able to mobilize with fractures like this? I just haven't seen that. Have you had patients?
Well, I mean, they start, obviously, yeah, that's the dilemma.
So we do as well. I think,
I don't know if that was me or not, but
That was Stover trying to say something, but he doesn't have enough connection to get through.
oh, okay.
I got a connection.
Okay.
No,
No,
yeah, it's pretty rare. But again, you know, you're starting off bed to chair, and then you're working that way. So I'm not saying that we do that frequently at all. You know, maybe once every several years, for sure.
Gotcha.
Yeah, I mean, I'll speak up and just say that we treat the majority of the people non-operatively.
The problem that you run into in that circumstance.
Sorry, Stover, we're not getting your comment.
No, my only point is I'm with Steve, but we treat a lot of them non-operatively, but if they do well and they get mobilized afterwards, it's a very challenging reconstructive case at a later time. So I think if they're relatively physiologically healthy, I would rather do it in the initial setting than a delayed setting.
Yeah, I don't want to belabor the point, but I'll just say for these people who fall down and have a very low energy fracture, my experience has been they don't have a tremendous amount of pain, and they can actually be up and mobilized fairly well. You know, if she's in a car wreck, that's a different animal. And our total joint guys prefer to do them in a delayed fashion. So if they have pain later, they get a total hip. Having said that, the majority of them don't come back for a total hip. They do reasonably well. So I guess I'm an outlier in the whole argument that this is like a hip fracture. But the point is well made that I think that if they're an active person, it all boils down to their physiologic age and how functional you think they are, and how much pain they have and how much deformity they have, I guess.
I think, you know, a lot of those low energy injuries, though, that you're describing, Steve, are ones where the cortical displacements are not as significant maybe as this is. And there may be a lot of impaction, but the femoral head almost molds itself a new location into the impaction. And people do tolerate that situation quite well. This really has pretty dramatic columnar displacement that I think might not be so amenable to non-operative management.
Yeah, and that's what we thought too, Mark, in terms of putting his whole picture together. And so looking through this, I mean, those are our kind of discussion points. We haven't talked about those last two so much, but I mean, I think his diagnosis is an incomplete, meaning we saw that the internal iliac fossa was not complete, but it's a high anterior column posterior hemitransverse variant with just that little bit of caudal peripheral cartilage still potentially on the intact ilium. There's a large segment of the cranial impaction that we saw. This patient was put into preoperative traction for the reasons that we know about. And then when we talked about all the treatment options with him and his family and putting him together, he was not a candidate we weren't planning for an acute RF or any sort of arthroplasty. And so we thought definitive fixation was amenable for the reasons you mentioned, Mark, in terms of the large segment of dome, and it wasn't too comminuted. And so the chance of getting that into a reasonable location was with a high likelihood. And then I think we'll talk about it maybe intraoperatively in terms of the different strategies in terms of how to reduce overall segments of impaction in this location. And two different methods of how to do that. And so just quickly go through this, but this is kind of the stepwise thought of how I was trying to address this patient's problem. And I think that this is a supine anterior approach, like we heard from Dr. Williams and Dr. Stephen and Dr. Mayo, in terms of addressing anteriorly based columnar patterns through an ilioinguinal or some sort of anterior variant approach. But once the approach is done, addressing the impaction, getting some sort of backfill to maintain the reduction of that impaction, and then working down columnar stability. And we'll kind of go through these in a stepwise fashion. And so I think one popular strategy or one feasible strategy is to work through a fracture line to get access to visualize and or reduce the impaction. And this is just a picture from a paper by Archdeacon and his group out of Cincinnati, just working through an intrapelvic approach to get access. And I think I put that iliac oblique that we can see on the right in terms of, I think, really good visualization of that large impacted segment. And I think the talking point, I'd love to have some faculty's input in terms of how they're doing that and in terms of the sequencing. Is it putting the columns back down, either the anterior column and then addressing the impaction, is it both columns down and then addressing through some sort of cortical window and doing indirect reduction. Mark, any thoughts on that?
Yeah, I mean, I think there's been a couple of things described. Certainly, making a window above and impacting down from above always seems to be a little unreliable, particularly when you've got multiple, impactions. It's sort of like trying to tamp up a comminuted impacted plateau without actually visualizing the articular surface, and you just don't exactly know why it's not looking good, but all of a sudden you start losing your subchondral shadows, and it's because you're rotating or shifting your fragments. So that it's always a little bit less reliable than being able to tamp the head down like this under direct visualization. I think Gila Flama also wrote up reducing the anterior column first and then sort of accentuating the posterior column displacement to work same through the fracture line. But at least you then have the femoral head and the anterior column sort of back in their normal position, and you've got something to where you can reduce the impaction to it. This situation of reducing the impaction first, I think can work very well, but it mandates the femoral head has to be in the normal location, and that's sometimes a very difficult thing to judge when you don't have any intact segment that you can actually look at and judge the reduction of the femoral head. So how did you position the femoral head to be able to perform that, or how do you?
Yeah, and so here's our patient intraoperatively, and we can see this is working through the interpelvic window or the medial window of an ilioinguinal, and we can see working through both fracture lines. The anterior column is not reduced yet, and we can see that, I think, just like you said, Mark, getting a judgment of where the femoral head is in space is, I think, difficult. And I think we're getting maybe fooled here a little bit. I don't think, without the full CT to show you, I can't promise you, but this is not that segment of cartilage that we were planning on being intact. I think this is actually the more caudal down here is where that is. And we can see it maybe better on the picture on the right in terms of a slight difference in angle or projection, but that's that little impacted segment. And so, with 15 pounds of just distal femoral skeletal traction, we thought we had a reasonable alignment of where that femoral head is in space. And so without putting the anterior column back down and trying to work underneath that or work through the posterior column, we thought we had really good access, like we saw in that picture, to do just what was kind of described. And so we accessed that large segment impaction here with just a curved osteotome. We can see we can mobilize that segment and then push it directly down onto the head like we see here. And then looking at, just judging our head in space, there is, I think, this kind of more posterior lateral impaction that's free that we did not address for this patient. But again, we're kind of judging our head position based upon what we think is our intact segment, which is seen posteriorly here.
And this was with longitudinal traction only, or is there lateral traction as well? This is
pure just longitudinal.
I think it's really a good idea in situations like this. And as you pointed out, John, that as this intact portion of the sourceal becomes vanishingly small, it's very difficult to use this. But I try to get a perfectly controlled contralateral AP pelvis and then match my head position to whatever that small impact of source piece of sourceal is. And that's really, I function primarily not distal, but more lateral traction. And obviously, if this is trying to become a both column, if it actually made it, that would be no longer useful, except that you look at the midline to femoral head centered position to try to replicate that. But I think the lateral traction is really useful in most of these.
John, can I ask a question? How high, it looks to me like you've kind of gone kind of subchondral almost, and looking at the 3D, there was a lot more cancellous bone on that. So when you use when you use a punch from a window, obviously you're punching right down onto it. When you do this technique, you're kind of obviously trying to get as high as possible, but is there any significance to that, or does it matter? Or?
Oh, I think what you said is the perfect thing. I mean, I think we're working here through this window. That's our visualization, and so we're limited a little bit by the cortical bone that's still there in terms of trying to get a big shelf. And so I think the angle we try to get as much bone as we can to keep that whole piece as truly one piece and to mobilize it and be able to control it accurately. I think we're trying to take as much bone. And so again, with osteoporotic bone, I think everything just kind of starts to compact easier than just a younger patient, obviously. But here we're trying to take as much bone as we can to keep it all contained within one piece and make our plan viable. And so moving on, we just, I think we're mobilizing and just here's one shot. And so it doesn't happen in one shot, but we're working in and trying to get that back down on the head and holding it. And then once it's there, we can hold it directly. We can put wires, we can do other techniques to maintain the reduction that we think is adequate. And I think as you can see on the right, I think in comparison to our what we're counting as the intact, I think that again, the head segment is down to where it's supposed to be. And then for this patient, I think maybe a discussion point or maybe not in terms of what to use, but we use a combination of cancellous chip allograft and just a synthetic calcium phosphate combination just because of a significantly large void that was there. And so once that's done, I think we go down the algorithm that was discussed for the anterior base fractures. And so we're having anterior column reduction, and we can see just a modified pelvic reduction clamp through the anterior pelvic approach to get that anterior column back down to a cortical read on the brim. I think sometimes the tricky parts for that are for those incomplete fractures where the mobility may not be there. And I think for younger people that has the same phenomenon, it's not quite as mobile. For him, we were able to mobilize him, I think, adequately with a reduction on the pelvic brim and the articular surface through fluoroscopy, that we did not have to complete it. But that's always, I think, in the back of our minds if we're not getting that mobility that we're seeking. And so once that reduction's down, we're putting a pelvic brim plate that we can see here to act in buttress for the anterior column. And there it's just held with one screw initially to check the location and reduction and make sure we're happy with it. But then we go ahead and supplement with more screws to get good plate bone opposition. And then we start fine tuning that posterior column reduction. Initially, you can see on that picture on the left, we're not so much worried about the posterior column. I was more focused on the anterior column. And once that's down, we're happy. Then we start fine tuning the posterior column. And you can see, again, just the vector and the clamp that was needed to do it is not straightforward and simple. And you can see his bone quality is not good. And so augmenting the clamp with a foot plate and stuff was necessary to get that posterior column component back out and lateral. And then once we're satisfied with that, we move towards some antegrade posterior column screws that were been discussed. I think there's, multiple points of fixation is beneficial for this patient, just for the reasons we mentioned to maintain his reduction. And again, I don't think we're planning on him being very compliant with restricted weight bearing. We're almost planning on him being mobilizing as much as he can tolerate. And so here we're going to put, I put two 3.5 millimeter screws and then one 4.5 that's outside the plate. And we can see that here. And then for his stability, again, we're adding and augmenting with multiple planes. And so here's an integrated anterior column screw. And then finally, the last step was to put an intrapelvic buttress to keep and maintain that posterior column that's been reduced and held with the posterior column screws, but again, to prevent further displacement from that medial vector. And so those are his final intraoperative fluoro films, and just a very limited intraoperative image through just a serum that's been mentioned in terms of being able to get intraoperative advanced imaging, and just showing, I think, an adequate reduction of that marginal impaction just on those select cuts you can see. I don't have full long-term follow-up. He's a relatively new patient to me, but here's his final post-operative films or immediate post-operative films. And he was mobilizing in the hospital. He's been discharged to a skilled nursing facility currently.
So thoughts or techniques about internal fixation, stabilizing your impacted segment in addition to the allograft and substitute augment?
I think it's a great question, Mark. In terms of some sort of rafting screw or other implant to hold that help hold that impacted segment down, I think is good. I think we augmented with a large volume of bone graft, and then we were trying to get some sort of fixation through the intrapelvic plate. And I think is maybe a sequence problem for us. But once we had our antegrade posterior column screws down, there was really a kind of a traffic problem with the screws that were resisting there to get any sort of fixation there. And so we didn't. I think it's appropriate consideration to try to augment that, to make sure that, again, you've worked hard to get that impacted segment down, and then doing something to make sure it stays there is a very good idea.
Yeah, this is where I think that that having the middle window of the ilioinguinal open also offers you the opportunity to go straight anterior posterior with screws that are just above the impaction, that are out of the way of your posterior column traffic. Because you're right that, you know, having the buttress plate, having the posterior column fixation really eliminates a lot of options for internal fixation, but the second window opens up a different plane of fixation there. Question for the faculty. Corey Collins wrote up stabilizing the impaction with using long 2.0 wires from the AIP going just above the articular impaction and then bringing them out through the buttock, analogous to a plateau, a lateral plateau, where we bring wires out percutaneously out the skin on the medial side. And he's talked about bringing those wires out through the buttock and then backing them up so they're flush with the, you know, with the impaction segment. Has anybody tried doing that and have any points, concerns, or thoughts? No.
I mean, I'll say I've tried that just as you described, and I've been able to do it. I think sometimes just the location of the impaction and the vector that you're left with to safely place those wires, it ends up being a very low trajectory that's hard to keep within the sterile field. And so I think just the factor of where that has to be and what vector you're able to do with their habitus and their impaction of the vector, it can be challenging, but it is possible.
Yeah, I think his thought was then that he could use them for a cannulated screw coming back over the wire potentially. But
absolutely.
Great. Other thoughts or questions from the faculty?
Hey, John, this is Ray Wright. I thought it was a great case, you know, and one of the things that I think might have got lost to the audience, you know, we're sort of talking about sequencing of the reduction of your of the impacted segment versus the columns first, you know, and maybe mention it, but I'm not sure. When you have a large impacted segment like that, a lot of times that impacted segment obstructs or keeps your columns from being able to come down. Have you run into that in your clinical practice at all? And was that really the reasoning for your sequencing here?
Ray, that's a great point, and it's absolutely true that sometimes that can impede your reduction. That wasn't the case here. That's definitely a possibility. Again, I think it's one of those, you know, hundreds of things that are running through your mind in terms of intraoperative decision makings, but it wasn't the case here. And we use that to primarily do, as we talked about, just for the access. And so I think you're choosing your algorithm based upon a very fluid environment, but I think that's for sure something to consider, and we're always thinking about it. Thank you.
Thank you.
Yeah, and I think being able to, you know, in the situation where you disimpact the articular impaction and backfill the defect, if you then reduce your columns or have, you know, and realize then at that point that the impaction isn't quite where you want it, you still have the possibility to do something like a osteotomy above and impact from, you know, from above. So I think you've got to know all your potential techniques and be able to go back and forth, because these can be really challenging to obtain the reduction.
So Mark and John, maybe you can we go back to the AP? So, I mean, this just won't spend too much time on this, but I mean, this is a very common appearance of some residual medial rotation of the posterior column, which is ubiquitous in these patterns just because of difficulty controlling the posterior column from the front. And, you know, I'm just looking for techniques that work, because hanging the posterior column on anterior to posterior screws doesn't seem to work very well. A low exit point like this for the posterior column makes it relatively less significant, but if it's a relatively high exit point, then your infrapectineal plate is controlling the quadrantal surface, but really nothing is controlling the posterior column rotation, and that requires really extending almost to the ischial spine to push laterally, and may be insignificant, but there are patterns where it becomes quite significant. And so, I mean, obviously the trajectory of those screws is critical. And I've gone from outside in the medius pillar, try to start laterally and go into the posterior column. I think I've tried every technique I can imagine. And a lot of my x-rays still have posterior malrotation. So
Yeah,
any points there?
just to be clear for the participant, what you're talking about the change in appearance of the obturator foramen and the change in position of the teardrop in relation to the ilioischial line as your key here.
Yeah, I mean, you can even measure from midline to the hip center, because that's even slightly medially displaced as well. But I mean, I think the aggravating part of doing a hemitransverse from the front, particularly the more sagittally oriented it becomes, is that number one, your clamp position is difficult. Number two, your screw position is, in a sense, illogical as far as maintaining position. So.
Yeah, and I think that in these older patients where the bone's typically a little bit flexible, we can make what we can see of the posterior column reduction visually. We can make it look pretty good just by virtue of the fact that the cortex will bend a little bit. But yet, as you see, the femoral head will sometimes still follow the posterior column, and it doesn't actually lateralize and derotate the way that you think it is based upon what you're looking at visually. I use screws from outside in, screws from inside out, plates that go further down on the quadrilateral surface, but still everything is dependent on the ability to create a laterally directed force on the posterior column, and it's really difficult to do in osteoporotic bone. So I thank everybody for all of your questions. There were really a tremendous number of really good questions I saw going by. I think Dave Stevens, some of the other faculty members were answering them. But what we ask you to do is now to reflect on the cases that were presented. You can go back, you can watch the video, you can maybe stop and pause and look at some of those x-rays and really focus in on some of the points that were being made so that you truly have a good understanding of those cases. It's very difficult when you see complex cases go by quite quickly, and we recognize that. So what we'd like you to do is to review the case presentations from today, and any unanswered questions that you didn't get, we'd encourage you to submit them back by answering the email to Doreen, and then we'll collect those questions, and we'll start off our Thursday evening session by addressing some of the questions that we received. So I did want to remind you that this session continues with a special session on Thursday. It's 8 o'clock Eastern Standard Time, which we understand is very difficult for our participants that are in Europe or in Asia, but we needed to find a time when everybody could be available. So we hope that you will be able to join us for some additional case discussion. We've got an hour session planned there with 2 to 3 more cases to discuss as well. Again, you'll get a link to the recording. It'll be sent out 24 hours after this webinar, but you could be able to find it posted on the AO Trauma North America YouTube channel as well. So remember that if you are going to join us for next Thursday evening, it's a separate registration link because it was added in after we established the registration. So it will be a different Zoom link to join into that than the link that you've been using up to this point. So you can either take a screenshot of this right now or it'll be sent out to all the participants who have joined us so far. And then our final week, a week from today, we'll be concluding with special problems such as elderly patients, osteoporosis, and complications, etc. So thank you all very much for joining us on today's webinar, and thank the faculty for all of their great cases and insightful comments and discussion. We hope that you continue to join in with us, and look forward to seeing you all virtually next Thursday. So thank you very much. Evaluation questions are coming up now for you to answer as well. And thank you all for your attention.